Good morning, everybody, and thank you to SAGES and the moderators for this opportunity. I'm a minimally invasive general and a bariatric surgeon out of the Boston community, and as a consequence, let's see, I have no disclosures. So my talk is, will obesity dictate how we treat reflux in the future? And in preparing this talk, I thought it would be prudent to break this question down into 4 sub-questions. And then if you're able to answer with the current literature these questions, it might be able to answer the question at hand. So these questions being as follows: are obesity rates rising? Is the treatment of obesity changing? Will newer obesity therapies continue to treat reflux? And last but not the least, will third-party payers cover obesity reflux therapies? So a quick review of obesity statistics. This is CDC data from 2021. The US obesity prevalence is about 41.9%. In the last 20 years, the prevalence has gone up from 30.5 to 41.9%. Severe obesity, defined as BMI more than 35, has gone up from 4.7 to 9.2, basically double-fold. And more than 7 in 10 adults over 20 years of age are either overweight or obese. Ward et al. Published in the New England Journal of Medicine that by the year 2030, approximately half of all adults in the US are expected to be obese, and probably 1/4 severely obese. These are alarming numbers. Some of the bariatric surgeons in the crowd might be familiar with this. We present this to our pre-op patients. This is a behavioral risk factor surveillance system. They come up with state-specific obesity prevalence. Basically, anything in green or yellow is okay, but orange, dark orange, and maroon is bad. And that is about 30 to 40%, 45% obesity prevalence in the states. So what is the association between obesity and reflux? And we are all very familiar with this, but this is a pivotal white paper published by Peter Now and Dr. Ketan and group as a SAGES Foregut task force, looking at the surgical management of reflux in the obese patients. And it is good to know that they came up with things that we already know about, but further reinforces our belief. What they found was one of the most common conditions affecting obese patients is reflux. As an individual, severity of obesity goes up, the frequency and severity of reflux symptoms go up. Each 5-point increase in BMI, the Demeter score goes up by 3 points. And BMI is strongly associated with risk of esophageal cancer. So for the sake of this talk, when you think about reflux treatment in the setting of obesity, there's 2 ways you can look at it. One is treating reflux in the obese patient and perhaps performing fundoplication, which is totally acceptable, or treating their obesity and then and secondarily affecting their reflux. So that could be either metabolic bariatric surgery or anti-obesity medications. So the group also looked at these individual procedures, and they found that, for example, the bypass, several studies show benefit of the bypass for reflux. There's decrease in symptoms, use of PPI, H2 blockers. There's objective decrease in total esophageal acid exposure. And the expert recommendation in the paper was that bypass be the procedure of choice in patients with reflux and BMI of more than 35. What about fundoplication? There's data both sides. For example, Perez et al. Looked at 225 patients, and they found that obese patients had a 31% risk of recurrence after fundoplication as compared to only 4.5% patients who were normal weight. Morgenthau et al. Showed that they looked at pre-op factors that would cause fundoplication failure, and they found obesity as to be an important factor. On the flip side, Peterson et al. Showed that Nissen is as good as a gastric bypass in normalizing esophageal acid exposure and symptoms at 6 months post-op. Rafter-Paulus's group showed that Roux-en-Y gastric bypass is very effective in failed fundoplications. And the last one, the Kellogg et al. Group, they did a very interesting study looking at anatomical reasons for RAP failures, and they found that in obese people, there were more RAP disruptions as compared to normal weight patients, which had other reasons for RAP failure. So it makes sense, like Dr. Ujiki had mentioned, increase in intra-abdominal pressure causing RAP disruptions. What about the sleeve? I think in 2024, most of us will agree that sleeve may not be the best operation for reflux. There's consistent data that shows sleeve to be inferior operation for reflux. In the bariatrics outcomes longitudinal data, they looked at almost 5,000 patients. Patients who had pre-op reflux underwent the sleeve, and 84% of them had persistent symptoms post-op. We got to talk about CADS and reflux. It's a newer operation being increasingly adapted by bariatric surgeons around. And this is a study published in 2023 looking at mid and long-term follow-up. It's a systematic review of 11 papers looking at up to about 10 years of follow-up. And turns out there's decent remission rates for reflux with this AD, about 53.2%. Full disclaimer that there are some late complications, about 3.6% chance of reflux at about 10 years. So then the elephant in the room, what about anti-obesity medications? I think no talk about obesity is complete in 2024 without talking about these medications. We've all seen a significant uptick in use of GLP-1 receptor agonists, semaglutide, liraglutide, very good weight loss, 15% total body weight loss. But how about reflux? How does it impact reflux? Now, there's a lot of case reports out there talking about delayed gastric emptying. I have patients who've had those problems. But when you specifically look at reflux, there's no mention of reflux with the obesity medications, not that I'm aware of, and there's not much literature. Tirzepatide, the GLP, GIP agonist, also gives you excellent weight loss, but nothing about reflux so far. So we need more data. This is a quick slide comparing the percent total body weight loss with all these different maneuvers, and it's very impressive. Tirzepatide's at about 20%, gastric bypass is 32 to 35%. So this is probably going to be part of our armamentarium in treating obesity in the future, and I think we need to be aware. Again, not to belabor the point, but this is a busy slide, I apologize, but the bottom line is that there's a lot of newer drugs in different stages of clinical trials on the market for weight loss, and I think we'll be seeing a lot more in the future as obesity and reflux surgeons. So just to conclude about the obesity meds, we do know there's gastroparesis. We don't know if there's worsening reflux. Is there any effect on reflux? No idea. But that begs the question, in patients who don't have insurance coverage for bariatric surgery and they're obese, could you bridge them with anti-obesity medications, bring their obesity down to a normal level, and then perform a fundoplication? We might be doing this in the future. Speaking of insurance barriers, unfortunately, a lot of things we do as surgeons is affected by what insurance coverage they have. We published this data last year looking at surgeon experience with insurance and their difficulties in getting bypass covered for reflux. And what we found that a majority of surgeons would offer gastric bypass for pathological GERD, and about half of them would use BMI criteria of 35, but 22% of surgeons, regardless of BMI, would offer bypass. Unfortunately, 74% of us face insurance denial. So this needs more advocacy. So coming back to the 4 questions to wind up, are obesity rates rising? Yes, we saw that. Is the treatment of obesity evolving? Yes, we have new procedures like SADI coming up and obesity medications. Will neuro-obesity treatments continue to improve reflux? I think any procedure for obesity that we're developing has to address reflux. So yes, for SADI. Not sure about the anti-obesity medications just yet, but doesn't look like it at the first look. And what about third-party payers covering bariatric procedures for reflux treatment? This will be a strong determinant. This needs advocacy. So in conclusion, obesity will continue to strongly impact how we treat reflux in the future. Approach will be tailored to the patient's BMI and third-party coverage. Bridge with obesity medications to fundoplication may be a possibility. And a quick note, with the newer ASMBS IFSO guidelines for lower BMI patients to be able to perform bariatric surgery, I think more surgeons will be inclined to offer metabolic bariatric surgery in lower BMI patients. And I think we need continued advocacy. That's my time. Thank you.